Good evening, good afternoon, and good morning. This is the 1668th day of continuous webinar conducted by International Forum for Promoting Homeopathy. Today, our guest is Dr. Indraneel Bawadekar. Let us begin the session with 1 minute silent prayer. Thank you all. The International Forum for Promoting Homeopathy comprises of homeopathic lovers, students, and doctors. We have 3 sessions every day. The first session of the day is already over in Hindi from 7:30 to 8:30. From 8:30 to 9:30, we have an international session in English. And from 9:30 to 10:30, a local language session in Malayalam. We are uploading the videos of the same on the very next day itself so that those who missed the session can watch it again. And you can subscribe the same with your friends as well as homeopathic lovers. The purpose of this forum is to take homeopathy to every home around the world. And today, our guest is Dr. Indraneel Bawadekar. As you know, the doctor has presented some papers some 1 month back, and it's really a brilliant session. And he is a person who is having a lot of degrees in his kitty. He has completed MD in homeopathy, then LLB, then DMJF, as well as PG in diploma in forensic medicine. And he is known to be as a homeopathic nephrologist as well as a homeopathic lawyer. Yes, not only the homeopathic lawyer, he's a lawyer by profession also. And he is practicing at Narayanapath, Kothurdu, Pune. And he has more than 31 years of clinical experience. His subject of interest is to explain medical laws to doctors in simple words. He has taken more than 50 CMAs for doctors and students. Today, Doctor will be talking about a very, very important subject, that is diabetic nephropathy and its homeopathic management. So I hope all of you can watch the session with excellent attention, because that will definitely take you to homeopathic level of a homeopathic nephrologist. So we proudly welcome Dr. Indraneel Bawadekar. Welcome, Doctor. You are muted, sir. Please unmute. Please unmute.
Yeah, sir, am I audible now?
Yes, yes, yes.
Yes. Okay. Sir, firstly, I am very much thankful to IFPH Forum for giving me this opportunity. All the senior doctors, Dr. Sahani sir, Dr. Dina sir, Dr. Ganesh sir, Manoj sir, all the gents as well as the ladies, I really appreciate they are working tirelessly for so many days and giving us opportunity right from budding homeopath to senior homeopaths. So I'm very thankful to all of them. Secondly, today we all are going to discuss a very important subject, that is diabetic nephropathy. I will request you all to be relaxed and just go to the session. I will be talking in 2 sections. One is about understanding the nephropathy and homeopathic management of diabetic nephropathy. So we will be beginning. I shall share my screen. Sir, kindly see if you can see it.
Yes, 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 you can share now. Your
Yeah.
Yes,
yeah.
visible. Visible.
Yeah.
Everything.
Yeah. So friend, today the subject is diabetic nephropathy. The word nephropathy is a clinical word. It relates to damage to the kidney, which a diabetes patients usually face. Friends, usually I have observed in my 31 to 32 years of practice, many deaths in almost all aged people are of 2 things. One is basically they die with a sudden cardiac arrest because of diabetic complications, mostly in sleep or in ICU. And mostly in ICUs also death unfortunately occurs because of renal failure. Renal failure because of long time standing diabetes as well as hypertension. Many a same time you must have seen your grandparents, your relatives, somebody nearby, they are in shock. They have got oliguria. They have got low BP, so they are not fit for dialysis. And ultimately, no urine output, and person has to take an exit from this world due to renal failure. If diabetic nephropathy is controlled in time, there are chances of saving such deaths around 90 to 95%. Homeopathy can cater good medications as well as support to all these patients and really help mankind. That is our main motto. Today, I'll go to the introduction. Now, I will make it short as diabetic kidney disease, DKD, or DN, that is diabetic nephropathy. Now, this diabetic nephropathy is a significant complication of diabetes mellitus leading to chronic disease, that is CKD. You must have heard this word many times, that is chronic kidney disease or chronic CRF, chronic kidney failure. They all have the same meaning. In fact, another word is ESRD, that is end stage renal disease. These all words are used in all ICU and all admitted patients. We must have seen this. In India, the prevalence of diabetic nephropathy has widely across different studies is very wide, and different studies in different populations have been done. Usually, it ranges from 0.9% to 62.3% across regions of India. It's almost, you can say, two-thirds of the population having diabetes, they have diabetic nephropathy after a few years, which is significantly high. Additionally, a multi-center study in India found that composite prevalence of diabetic kidney disease is around 35%. So these all statistical figures, they vary, but the patients suffer, and every third patient or fourth patient is a diabetic is nowadays study. But in future, almost third or fourth patient becomes to be having diabetes, which is for long standing, they have to have a CKD. This we should keep in mind. Now, sorry. We'll take an overview of this. Diabetic nephropathy, it is a serious complication. Type 1 diabetes, we all know, that is IDDM, that is insulin-dependent diabetes mellitus. In these patients, this is seen in very large number. Normally, homeopaths get patients of type 2 diabetes, which are 30 to 35 years plus of age. This is also called as diabetic kidney disease. In United States, about 1 in 3 people living in diabetes have diabetic nephropathy. Now, diabetic nephropathy, it affects the kidneys. Usually, we know that the kidney has a function of removing the waste products from our body. That means the nitrogenous waste products, the excessive fluid, it all gets hampered, and usually patients suffer because of this all toxins accumulated in the body, and also they are accompanied with hypertension also. Yeah. Now, what is the pathophysiology? See, high glucose in the bloodstream, it damages the glomeruli, and which leads to proteinuria, and they decline or they reduce the kidney function. That is a pathology. Now, they are being labeled from stage 1 to stage 5. We will not go in detail, but I will request all attending homeopaths kindly understand the pathophysiology of diabetic nephropathy, because only hunting the symptoms and matching our materia medica and repertory with the symptoms give partial relief. They don't give total relief to the patient. If we really understand what is the pathology, what is going wrong because of this high diabetes, surely we will be able to help our patients in more accurate way. So this, you may think this is a revision of undergraduate level, but I will request everyone to just understand in short. We know this is the anatomy of the kidney. We know these are the ureters. My mouse will show you. Yeah, this is the cortex of the kidney. Blood enters the kidney through the artery. It comes out from the vein, from inferior vena cava. It goes to the heart. We are basically going to concentrate on this outer surface of the kidney. This outer surface is called as the cortex, and this cortex has the unit of filtration called as nephrons. These nephrons, they have glomeruli. We'll go ahead a little bit, but kindly look at this picture. See the picture of a nephron. This picture is very important because homeopaths can help people in managing the diseases at this level also. The blood enters the nephrons from the afferent artery. You must have seen the left side red one, that is the afferent artery. This brings down the blood in the nephron. Glomerular trough is there. It gets filtered, and from the efferent arteriole, it goes to the vein, and then it joins the inferior vena cava. The waste products are basically filtered by osmosis process, and the urine is then passed through this nephron. When we come down, here is the like descending tubule, loop of Henle, and ascending tubule. This is the anatomy which we should keep in mind. We'll go in more colorful way. See, this is the glomerulus. I showed you that this is an afferent artery. This is the efferent artery. The dirty blood means the blood which enters from the artery and it has got mixed with all the nitrogenous waste products. They all come over here. here the filtration occurs, and then the blood goes ahead. Yeah, from the efferent, it goes down, and from the tubes, again it gets reabsorption, again it gets refiltered, and again the blood is sent back to the vein. That is called as a clean blood. So the blue vein has been labeled as clean blood, which is free from nitrogenous waste products. Here is how the glomerulus looks under the electron microscope. We all have seen colorful pictures in our biology books, in our medical books, but this picture will illustrate how thickly there is a mesh of the nephrons, and all these nephrons, they have all small membranes, and these membranes, they filter all the blood and remove the nitrogenous waste products from our blood. We will understand this nephron a little bit deeper way. Now we'll see that I told you, like the blood enters, dirty blood enters over here, and it goes inside the capillaries, gets filtered here, and again it goes ahead. Now, after filtration, the liquid which remains down these all dots, that is called as the filtrate. This filtrate is very important because in this filtrate, it contains glucose, amino acids, salts, water, urea, creatinine. Now, from the filtrate, it gets absorbed in these arteries, it goes down. From the small capillaries, again there is a refiltration and reabsorption of the excess fluid. Now, glucose is reabsorbed. Then ammonia, amino acids are reabsorbed. Salt is reabsorbed. Water is reabsorbed. And urea and other toxic products are again sent ahead after filtration to the ureter, and clean blood goes from inferior aorta to the heart. So the filtration system works in this way. Our main idea is to understand this filtrate. Now this diagram will slowly concentrate on this diagram, which will explain us exactly what happens in diabetic nephropathy. So kindly look at this. See, from the left side, this is called as afferent artery. What is an afferent artery? Which brings blood to the nephrons. This artery is loaded with glucose, uncontrolled sugars. Then the blood enters over here. Then here filtration takes place. And after filtration, I told you that the waste products, osmosis occurs, the waste products are removed, and filtrate again goes down and gets refiltered. After this process, the blood comes out from efferent arteriole. So this efferent arteriole will again carry the blood back, okay, after filtration. Now, because of the high pressure of the blood, or we can say loaded with glucose, the pressure also in the afferent arteriole increases. This artery is very small, it's less than 1 millimeter. So what happens here down at the glomerulus level, there is a load on this glomerulus. Then the filtration, what happens? All the filtrating chambers, they get expanded. Because of this expansion, the protein leakage stops. And when the proteins they start, they enter the filtrates and we see in the urine of the patient. So this is very important. First, there is a hypertension and a hyperfiltration. After that, slowly, when the blood goes out after filtration, here we can see these two deposits. These are atherogenous deposits in diabetic patients. They are very much prone for atherogenic deposits. And because of these deposits, the efferent blood again has an obstruction to clear it. And hence the patient develops blood pressure slowly. So we see that hyperdiabetic patients develop blood pressure. Vice versa, blood pressure patients can also develop diabetes because of this constriction. Because of vasoconstriction, this is angiotensin aldosterone system that we already have seen. All these things are due to the hyperglycemia. So the afferent artery which carries hyperglycemia, that is a main culprit to cause these problems. Now, when we go down, because of the increased pressure, this is a cross-section view of the previous picture. There is a cross-section view of this filtration unit. There is expansion of the mesangial cells. If you can appreciate these lines, here you can see that the mesangial cells which do filtration, they get expanded. And because of this expanded, here, because from these small dots, there is a protein leakage. This also amounts to inflammation and endothelial dysfunction. Because of inflammation also, they get swelled up and protein leakage starts. So chronic passive inflammation is most of the time responsible for these kind of nephropathies. Okay. Now we go to the stages. Now different stages have been recorded, but usually the stages are very important. We'll go slowly. The hyperfiltration which I told you from the afferent artery, basically When this hyperfiltration stage usually is from 1 to 2 years of uncontrolled diabetes. This stage is there. Here what happens, the GFR, so that means the glomerular filtration rate, usually it is basically increased. Normally the GFR is 90 to 100 ml roughly in normal individuals, but these patients can get 130 GFR, they can get 140 GFR. And here we see that the blood creatinine levels are below normal. Normally it is allowed from 0.8 to 1.5 grams per dilution, but here you can get 0.6, 0.7. And even a physician or a homeopath, I would say, will be very happy that the diabetes is controlled and creatinines are below normal, so the patient is doing excellent. But friends, not so. Is in stage 1 that we should understand. Because of the stage 1, these creatinine levels are decreased than the normal. In second stage, we call them as a silent stage. Again, after a few years, when there is uncontrolled sugars, slowly up to 5 years, we see that the GFR again it returns back to normal. So GFR which was more than 130, now this again comes to normal and it becomes around 90, 95 per ml. And also the serum creatinine usually becomes up to 0.9, 1, 1.2, 1.3, but definitely it remains below normal. So again, there is a confusion state. So we call it as the silent stage. The third stage is important. Now, third stage develops after again long period, 6 to 8 years, 7 to 8 years, where there establishes a microalbuminuria. We saw that the inflammation of the mesangial cells, they cause expansion at the filtration plant and protein starts leaking. So at this stage, albuminuria is there. Microalbuminuria usually is from 30 to 300 milligrams. That is the range of it. It is sometimes more than that also. Our urine reports usually show 1 plus, 2 plus, 3 plus, 4 plus. There are no numerical values available in urine routine. So once in a year, every diabetic patient should do a test for urine microalbuminuria. This is indication of a diabetic nephropathy, and we should never neglect it doing it, and we should also explain this to the patient. Now, when the stage continues, it goes to macroalbuminuria. Means albuminuria increases. Here it goes more than 500, more than 600, and the patients slowly start developing ankle edema. Sometimes they say that because of traveling, this edema comes in the morning, it goes away. Sometimes there is swelling of face. There are many symptoms we will see now what occurs in macroalbuminuria, where there is a massive protein loss. And if it continues, the stage goes to stage 5, that is the eighth stage, and we call this as ESRD. ESRD is the end stage renal disease. Here, to be very honest, from my practice point of view, a homeopath can give a supportive treatment, but the patient has to go for a renal transplant treatment. That is there either dialysis or he has to go for a renal transplant. So this stage is the end stage where the entire organ has. What are the complications we will see of this disease? Kidney is as good as important like a heart, because once the kidney is affected, you will get mental symptoms also where there is a cognitive impairment, forgetfulness. It starts in these patients. They get confused. Sometimes they are also because of the capillary microangiopathies, cerebrovascular disease they may suffer. They may get stroke also because of the nephropathy. Coronary heart diseases, these are also secondary to the diabetic nephropathy. These I have observed because many patients they get silent infarcts, or they are not aware that they have got a myocardial infarction very mild, but they keep on carrying on and accidentally it gets diagnosed. So this is also a complication of a diabetic kidney disease. Cardiomyopathy, where there is a deposition of all excessive lipids or is a atheromatous material in the walls of the heart. Hence, the pumping is affected and the heart starts expanding. When it expands more than two-thirds, then the patient starts becoming breathless. And usually, I don't want to blame any pathy, but normally a patient is put on a diuretic and he gets temporary relief. That is there. Peripheral vascular disease. This is also a complication of DKD, where blood circulation to all the extremities usually becomes less, and there is less blood supply. So, lot many symptoms are seen, especially in the digits of the hand as well as your legs. So, peripheral is more seen than the central. Foot disease, we all know that the patient has got numbness. Many a times, diabetic patients they get small injury that will never pain them, they will never harm them, but they will never heal also. And the patient keeps on carrying on months and months with the injury. and ultimately by bad luck sometimes amputation may be required. Bladder dysfunctions are also seen in CKD patients. Neurogenic bladder. I know many patients tell me, doctor, every 1 hour I get a call and I have to go for the urine. I go and pass a little bit of urine. So this is a silent neurological problem because of the problem of the autonomic nervous system of the bladder, and they get bladder dysfunctions. Neuropathy, we all are aware, tingling, numbness, and a loss of sensation to the nerves is very common in CKD. Males, they have erectile dysfunction. The erectile dysfunctions are usually seen in all diabetic patients. That is very common. But friends, all diabetics are not lycopodium that they get impotency. So we should basically, I'll go in further how to evaluate patients. But erectile dysfunction is a complication of DKD, not only of diabetes. Eye diseases, this is also a different subject to talk. Different retinopathies are there, which a DKD patients get. And our country, we see sudden blindness or progressive blindness is very common because of this eye diseases. Patients get multiple periodontal abscess, so they have to visit the dentist and take dental treatments. They go in depression, they go in anxiety, mood problems. This is also very seen, and these all are secondary to DKD that we should keep in mind. Many patients ask me, sir, tell me some rubrics for albuminous urine. Urine albuminuria and apis mellifica is very common in all the homeopaths. But we should know there are some other rubrics also which cover albuminuria. So in short, I'll just go from homeopathic point of view. We get rubrics, that means urine albuminous. This is a rubric in our repertory which indicates proteinuria and it is a sign of involvement. There is also a rubric called as urine sugar in bracket diabetes mellitus. Another you get as urine frequent urination. Urine scanty, decreased urine output in kidney failure. Many times we see in ICU there is a kidney failure, and what rubric should we take? We don't know. So this you can keep in mind that urine scanty you can take. Okay. Sometimes it smells like a fishy odor. You can take it as urine offensive. On passing the urine, it turns milky or cloudy. This indicates the infection or proteinuria. So you can take it as milky and cloudy because there is no direct rubric in this that pus cells are so and so in urine. So this medication is indicated. There is nothing because during Hahnemann days and the drug proving, laboratory values were not so much documented or not were so much discovered. So the during the drug proving, the symptoms were basically documented in the single blind and the double blind study. And from that, these rubrics have been prepared. So you should take this rubric. We'll go ahead in short. Now, what are the clinical presentations of a DKD patient? See, in early stages of nephropathy, they may not present with any symptoms. They are totally normal, but the disease is progressive and individuals might experience slowly 1 or 2 symptoms. Usually they see that is swelling or edema, especially feet, hands, and all the dependent area. Early morning face, moon-like face or swelling face is a sign of DKD, that is diabetic kidney disease, because of the retention of water. Somebody may complain of fatigue, tiredness on doing small work consecutively in a day. Patient says, doctor, previously I was not getting so tired, but nowadays I become very tired. Is it due to the disease or it is my age? But friends, DKD also contributes to it. We should evaluate it. Nausea and vomiting resulting from accumulation of waste products in the blood. Sometimes patient present with immediate nausea without any cause. They themselves also, they convince themselves and they try to convince us also. The doctor, yesterday I had food outside the hotel. Probably that is causing me nausea. Acidity. I have acidity from childhood. But no friends, this nausea is many a times associated with DKD that we should also keep in mind. Another clinical presentation can be shortness of breath because of cardiomyopathy. The heart pumping becomes weak and they get basically breathless on walking especially. And very in advanced cases, I have seen that the patient cannot lie down. When they lie down, they become breathless. And when they get up, the whole night they sit and they breathe because of the orthopnea. That is due to the fluid accumulation in the abdomen as well as in the pleural cavity. Loss of appetite is the initial beginning stage of all these patients because they have longing for food. So this we see in many patients. Foamy urine. Every time they go to the urine and there is a foam accumulated in the urine. Dry, itchy skin. Usually this is because of the toxins which are circulating in the blood. So there is a dryness, there is itching, and this does not relieve. Temporary, it relieves with some cold application or with some local tubes, but it continues for the patient. Muscle cramps are also seen because of electrolyte imbalance in the patients, especially at the night time when they turn from one side to another side. They complain of muscle cramps. And these cramps are due to electrolyte imbalance. These are all the presentations. We may not get all together, but one or two or maximum three, if we get, we should think of DKD in our mind. Now, what is the diagnosis? How to diagnose DKD? This is a question for all because once the blood pressure diabetes has been diagnosed, when to diagnose that these symptoms are normal symptoms or DKD, this test will guide you. There are some strips available which show your urine proteins that we should do once a year. So once a year you can do that and see if there are proteins. Kidney function test we all know, RFTs, renal function test once a year. Blood pressure monitoring should be done because today or tomorrow these patients are going to develop blood pressure. So this has to be done. So they can also in diagnosis help us. Now eye checkup is a very must because in eye checkup I have seen means I have worked with an ophthalmologist for 2 years to see what is a normal fundus of eye because even if you see you patient we try to see we are not ophthalmologists but normal fundus also is not seen when we try to see because we are not trained in that. Because of the high levels of the sugars, the retina gets damaged slowly. So there are retinopathies, different. That is a different subject. Sometimes, if time allows and if IFPH permits, we'll have a separate lecture for diabetic retinopathy. So eye checkup, I think every homeopath should do. What should we do? This is a fundoscope. This fundoscope is a small unit. I will show you. This is a small unit. You can see it over here. Yeah, this you have to put in the your eye with the patient eye. The pupils should be dilated mostly because the dilatation should be good. Otherwise, the retina is not seen. And mydretics are required to dilate the pupils. And from this, you can see the retina. And every year, we can definitely see the progression of the diabetic kidney disease. Or many a times, I have diagnosed the patients to have kidney disease without doing their any blood urine investigations because on the fundus it is directly proportional to the fundus changes to the CKD, we can say, or any CKD or diabetic kidney disease. So this unit, I think if senior homeopaths or a middle-aged homeopaths can definitely buy, the unit costs around 10 to 12,000, but the investment is worth to have in our clinic just to have the evaluation and the progression of the disease. We can keep an eye on that. This is a picture of the fundoscope. One is the patient side and one is the practitioner side. These things are very detailed to explain. I just put a slide over here so that you can view it. It has got different apertures. It has got different colors. Even I'll tell you, cataracts also can be diagnosed with this unit. You don't have to visit an ophthalmologist. A homeopath can also diagnose a cataract from this unit. So this is a very helpful unit along with our BP apparatus and our glucometers, I will say. Now we'll go to the treatment part. What is the treatment? Managing diabetic nephropathy. The treatment basically is sugar control. Those who have got good sugar control will hardly have these problems. They will never face this, even though they have it for long many years. So uncontrolled word should be strictly put under control. Same is with blood pressure. By any medicines, any pathy, or any treatments, the blood pressure and sugar should remain normal. That is the main motto of treating these patients. Lifestyle modifications are important. Good dietitian should give a diet advice, regular exercise, and smoking cessation for males. Diet changes of everyone up in every decade of life. At the age of 20 years, your diet is different. 30 years, it is different. 40 years, different. 60 years is different. And also in different communities, the diet things are different. So I request all the patients to once see a dietitian so as to get an individualized diet plan for them. You cannot have a blanket treatment for all about diet. Blanket suggestion, I will say. Medications also should be there. Homeopath can give good medications and also help in reducing the progress of the disease. What can we do for prevention? Regular monitoring, that means regular checkups of all sugar levels. Then our lifestyle modification, that means the balanced diet, the regular physical activities and weight management, like obesity, if you are there, if you are underweight, you should have proper weight management. Also, smoking should be avoided and medication adherence should be there. So this, that means following the prescribed treatments for diabetes and hypertension, they should be strictly adhered. Patients leave the medicines because their level comes to normal. Many times I have seen that BP patients, they leave the BP or the sugar medicines once they come to normal. And anytime we ask them, they will tell you the normal value. Sir, my sugar was normal. Sir, my BP was normal. But they don't recheck. They don't reconfirm. So this has to be done. Also, for preventing, early intervention and consistent management are the key points of preventing and slowing down the nephropathy. This we should keep in mind. Early intervention should be there if we suspect it. Now, conventional management is also there that helps like controlling the blood sugar levels, maybe by OHA or hypoglycemic agents, insulins, that depends upon the physician, that we can say, blood pressure monitoring and lifestyle, correction like diet, exercise, and weight management. This also comes in the conventional management. It is the same like we homeopathy. Now we'll go to part two. This is all for homeopaths now, us. What is our role in decaying? What should be done? How should we control DA? There are many questions I know in mind. But if you listen carefully, surely you will be able to help your patients. Now, what should be done? First, identify when the patient has come to you and in what stage. I've seen that many patients come to late, new patients specifically with breathlessness, lots of edema, raised hypertension, and altered, they're all sensoriums. They don't want to get admitted, so they come as a second opinion to homeopathy. So, friends, one should always be careful with clinically that whether the case should be accepted or no. If the case has to be accepted, it should be in our hands, and if it is to be hospitalized, be safe and talk to the patient that hospitalization is necessary and the patient has to be saved, especially in the fluid load. I have seen they come with breathlessness, all the fluid gets accumulated in the ascites, pleural effusions, and they also pressurize the homeopaths to manage them. Normally homeopaths here have trained to manage them with apis mellifica, epocinum I have seen, and they partially work. And medico-legal problems are also welcome because the cases usually are in admission state and we make tall claims and say that no, homeopathy will help you. So friends, kindly do not do this. First, assess the case. Just see if he requires hospitalization. If yes, you should refer him, or if it is manageable, you can treat him. Individualize each and every patient's health. All patients having diabetes do not have same health. They have different health. That's why theory of individualization is with us. So Dr. Hahnemann has talked. So you have to individualize the patient. Gather the PPP, that means the presenting symptoms, the persisting symptoms, and the predominating complaints. This all we have seen in seminars, but instead of PPP, what is the our mind? Write it on a paper, these three things, and write down the symptoms in front of it. So every time a patient may present with different symptoms. So the state where the patient has come presenting, that we should note down. What is persisting from long time, that we should also note down, and what is predominating, because many times physicals are predominating, sometimes mentals are predominating, and in some cases nothing is predominating, only pathological changes are there. Okay, now homeopathic treatment, there should be a holistic approach and individualized plans for each and every patient. We cannot give 4 or 5 mother tinctures together and give to everyone so they will be corrected. No, individualized. Normally, I observe that frequently used remedies in acute problems are Berberis vulgaris, Cantharis, and Apis mellifica. These are routinely used, but a remedy may differ. Also, we should keep in mind that when the patient comes to us with the different stages, our Hahnemann has given us the idea about the miasms. Every case should be considered for this. If the patient has come with stage 1 to stage 3, we should select a remedy on all the complaints which has got dominating of sora and psychosis. Because if the patient is in stage 1 or stage 3, and if we give him a tubercular remedy, partial results will be there and patient will complicate more with some aggravating symptoms. So this should be there. If the patient has come to us in stage 4, then we require antisyphilitic and antipsychotic remedies. So this we should also keep in mind. Stage 5, that is the end stage renal disease. Many a times pathological changes are grossly involved. So tubercular remedies and psychotic remedies are usually most of the time required. Storic medicines hardly work in this stage. But after all, this is my observation of 32 years of practice. It all depends on the individual and homeopath's observation. But these common miasms should be considered and they will definitely help you into your case solving. Now, integrated approach is also there. What is this? See, always keep in mind, the patient has come to you in the last stage. Homeopathy is always, it complements to the conventional treatments. We should never see that stop all the conventional treatment and take only homeopathy. No, the patient is going to complicate because he has come down to you in last stage when there is all organ failure. So as a complementary treatment, a homeopath should approach a case. He should explain the patients also, because patients usually come with a mindset that I will stop all the allopathic or conventional treatment and take only homeopathy. No, they should complement each other and should work together. There should be a multidisciplinary approach. So if you keep different branches along with in the last stage, usually the outcomes are really good. You can give good quality of life to the patients and you can extend their life tenure also. Especially I've seen in case of like fluid overload patients, many a times we are hesitated to give other conventional treatments or with the like by from the opinion of a nephrologist from conventional side. But when there is a medical emergency, to avoid the medical legal problems also, we should boldly take their help and manage these patients. Now, patients' education should be there about the lifestyle and adherence key. What education? Patient should frankly know that where is he, what is his state of kidneys, what homeopathy is going to help him, what other conventional treatments or hospitalization when they are necessary. These all points are to be explained to a patient. So we will be also safe, and even the patients will have a clear-cut idea about their disease progression and their disease management. So this approach should also be kept in mind. Now I'll tell you, because of diabetes, infections are very common. Usually patients get of decay in acute infections. It's like urinary tract infections, pyelonephritis, especially having those patients who are diagnosed to have medical renal disease on ultrasound. These infections are very common. So we should also be aware that these infections are presenting symptom of DKD and we should manage them. Now, for infections related to kidney disease, we have very much good rubrics in the repertory which we should consider them, because directly for infections we hardly get any diagnosis and remedies. So I will guide you through some rubrics which will be, there are many rubrics, but some rubrics common which will be helpful to you in managing these infections. Now, in general, when the patient is completely in septicemia, we get a rubric that is blood septicemia pyemic, where there are severe infections in diabetes. In fever state, especially if it is a septic fever or a very low grade fever, which is common in diabetic infections, we get a rubric as fever, septic, and low grade. This we should keep in mind. We will never get remedies fever 101 give this remedy, fever 102 give this remedy. We will never find in our repertoire. Even a fever, chills with fever and sweating, you can get in recurrent infection, you can get some good group of drugs. In generalities also, suppression tendency too. That means we see it in diabetic wounds, especially in the foot. You can get a rubric of generalities, suppression tendency too, slow healing of wounds and abscesses. Because we know all that Heparin silicia promote the abscess formation. But what about the slow abscesses? All diabetics have peripheral vasculopathies. So their wounds are going to heal very slowly. And in that case, hardly homeopaths get confused. So which rubric to be taken? So this definitely this rubric will guide you. We have got very good rubrics in our repertories. Now I'll tell you some common rubrics which see on the present we see by presentation of the patients in urinary tract infections or pyelonephritis. In UTI, we may get a urinary complaint where there is a burning and scalding. You can take a rubric as urine, burning, scalding during urination. This we can consider. When there is proteinuria or a first like infection because of pyelonephritis, you get a rubric called as a urine cloudy, turbid, purulent, pus in the urine. Sometimes this smells offensive. So you can take a rubric as urine, offensive, and foul smelling. Do not go at the lab reports immediately. Okay. Suppose the patient tells you, sir, I am having these complaints, but the lab report shows you that RBCs are present more than 10. Then you can take it as urine bloody and with pus if it is associated with massive UTI. UTI massive is very common in diabetics. Sometimes there is inflammation in the kidneys, so you can take it as kidneys, inflammation, nephritis, pyelonephritis. But inflammation in the kidneys is very difficult to diagnose at OPD level. Usually, this finding is a biopsy report finding. So many patients go for kidney biopsy at advanced stages, and there we get these reports. So in those cases, this pathological rubric can be considered. Then also you can get pain in the kidney region. So like kidneys pain, dull aching or sharp shooting, this you can decide. I told you there is a bladder involvement in DKD patients. So bladder cystitis chronic recurrent, because we see many patients have chronic cystitis and hence they get UTI. They have to frequently go for the urination. So this rubric will be helpful to you. Now these homeopathic remedies which are commonly used, that I'll just let you know in between, because there are many remedies which can pop up with individualization, but these are the common remedies in last 32 years which I have seen and helped me a lot. I'll just go in short. Arsenic album, when there is septicemia, burning pains, anxiety and restlessness. Many times we see that there is no anxiety, there is no restlessness. I have given arsenic, but it has partially worked. So we should have these key points in mind when arsenic is going to work. Apis mellifica, where the patient is hot, red and redness of the skin and the orifices. There is a edema, there is a burning pain and scanty urination. So like this remedy has been found to be helpful along with proteinuria. Cantharis is also there when there is a hematuria and painful urination. So we get cantharis. Terebinthena is there. I'll little go with a speed as because I have to manage the time in 1 hour. This lecture becomes quite big. So Pipersulf is there where there is abscess formation. Pyrogen. This also is a very useful where septic conditions are there and the discharges are offensive. In gangrenous foods also pyrogen has helped a lot. Sickle core also is a good remedy when there is gangrene involvement. Even carbuncle formations, this sickle has worked very well. I have seen in carbuncles diabetic. Berberis vulgaris is there where there are short shooting pains in the kidney region with urinary concomitants. Lycopodium is one of the king remedies where the patient has diabetes with kidney disease and there is a sugar in the urine. Okay. Now, diabetic nephropathy. Directly, you don't get any rubrics in any repertoire of diabetic nephropathy directly. We get this under these following headings. We'll just shortly go to this so that our brother homeopaths will find them very easy to locate these rubrics. You can see this kidney inflammation, nephritis, nephropathy. This rubric is available. Kidney pain region, we get rubrics. Kidneys enlarged. Many a time diabetic patients have enlarged kidneys, so you can directly take a rubric as kidneys enlarged. Tenderness, if on touch you find you take kidneys tenderness. Urine, you can take burning, urine, involuntary urination, sediments like I told you, you can take this. Okay. Now, different repertoires are there which give you different rubrics under different headings, and many times we are not able to find them. Directly, you don't get a rubric called DKD, diabetic kidney disease. So, Dr. Murphy has given some rubrics which I will just mention you. He has mentioned under kidneys congestion, passive, two remedies only, Protalus horridus and Hemimelis. Passive congestion is always there, which we saw the pathophysiology, and when there was a swelling up of the mesangial cells, that time these remedies they work very well. Now, kidneys congestion, dropsy causing. When there is edema and you see congestion of the kidneys, these all things are, these words are explained on the ultrasound report of the patient. So carefully read the kidney section in the ultrasound reports. They show that the kidney is congested, then the kidney is scarred. There are many medical renal diseases. These words are used in ultrasound reports. Now, kidneys degeneration fatty. This directly we cannot get it. Those who come with biopsy reports, there we can see this, and we can take this as a pathological rubric in like Murphy's report. Now, Murphy has mentioned kidneys edema dropsy from kidney disease. Edema can be from many causes. It can be cardiac cause, renal cause, hypoalbuminuria, anemia, many causes are there. But Murphy specifically mentions that in kidney disease, if you get edema, Seneco and colchicum are the drugs given for that. Especially in nephritis, where there are infections, he mentions as Apis and Hellebores. BBCR has also given very good rubrics, but they are not under kidneys. In BBCR, it is given as urinary organs, kidneys inflammation, especially of the pelvis of the kidney. Like this pelvis gets inflamed, I'll tell you, in many patients of kidney stones. Diabetic patients having kidney stones, there is silent inflammation going on the pelvis. And we get all the urinary tract infection and the RBCs in the urine, but we are confused what symptom to take or what rubric to take. So this rubric from BBCR is very helpful. Urinary organs, kidneys inflammation, pelvis of only three drugs, berberis, heparin, and lycopodium. Now, many times patients present to us of glycosuria that there is a biting sensation or burning sensation at their urinary meatus after passing. You can think of Merck, then muriatic acid, and also sometimes there is itching sensation in females. This is very common for the urinary organs. We can take them as itching urinary organs, itching in BBCR, where alumina, creosote, and more other drugs. William Borick is a book which we routinely use on our table. He has also mentioned some rubrics related to diabetic kidney disease, but presentations are different. He has mentioned under urinary systems, kidneys inflammation chronic. So we can see DKD patients in this rubric. If there is biopsy and you get interstitial nephritis, it's well and good, but the remedies can be aurum plumbum and natramyol. Then urinary system pylitis, where is near the pelvis, if there is inflammation and the system is involved in acute stage, you can have copavia and benzoic acids. These are the good drugs. And urinary system, if there is a pylitis in chronic states, he also mentioned chronic means a recurrent state, more than 3 to 4 times occurrence. Then the drug like juniper and chemophilia are indicated. And also Boric mentions urinary system kidneys pylitis calculus. So those are having calculus like staghorn calculus or small gravels or small stones in the kidneys. For them, pipermethacin and hydrangea are the medications. Then also he mentions about the congestion which is chronic. So like it is staphylococcus and digitalis because this chronic congestion also is associated with hypertension. Now I'll go rapidly. This is from complete repertory. When you get that there is advanced infection and there is a fibrosis, you get directly a rubric called as kidneys fibrosis. The remedy is iodized radiation. I have not used it, but it is mentioned in the repertory. Remaining kidneys inflammation in nephritis, he gives it in complete repertory acute medicines like terbinafine, holmium. Then also we see uremic symptoms where patient gets uremic spasms, convulsions, and we have to admit him. Then he shows that kidneys nephritis, urinary complaints in, he gives bacteria, cuprum urs, and carbolic acid. Out of that, cuprum urs has helped my many patients, which I have clinically verified. Now, kidneys inflammation, nephritis, vaccination after. See, recently we had COVID vaccination. I have received many patients of young age getting kidney problems. Their renal parameters are also increased. They are lining up into chronic renal failure. For them, we can take this directly the rubric kidneys inflammation, nephritis, vaccination after. Every time Silicea and Thuja are not going to work. So this gives good remedies like Apis mellifica, calichlor, mercork, and vaccinum. These are the remedies given in complete repertory. So they are really very helpful post-vaccination. Now, where there is an inflammation of the kidneys in diabetic patients, those who have calculus, like the parenchyma or the pylon, we get hepar, hydrangea, pipermethacin, and yuva urshi. This is also one of the good remedies. So friends, from this, I've just given you a guidance for these CKD patients. In last 2 to 3 minutes, actually, I wanted to show many cases, but I'll just go with one case so as to guide you how to select the rubrics and how a homeopath should take an approach in a DKD patient. Now, this is a case where the patient was obese, having DM since 7 to 8 years, and he only presented with the below complaints. Like we decided before, we will be considering the presenting, persisting, and period-dominating complaints. So this history was only given. What did the patient say? He said, "Doctor, I want to bring my creatinine levels to normal." When he stepped down into the clinic, I had taken many treatments, but I think probably I will have to take the medicines forever my life. Probably there is no fear, but he thinks like that. Okay. Also, the patient said, "I'm having vomiting after eating food from last week." That this is also a symptom of nephropathy. He was an advanced case, so like he had a biopsy done. So he showed me the biopsy done where the diagnosis was given as the nephritis. He also says that whenever I pass my urine, after passing, it turns like lime water color from many days, and sometimes it is foamy. And my recent creatine levels are 3.2 milligrams per dilution, and these levels are bothering me because at this level the patient is comfortable. After 5 to 6, he goes on dialysis, is my observation. I cannot tolerate fan and AC because even though there are summer days in here Maharashtra, but he says that I cannot tolerate that. Like he asked them to keep a shutdown. So like these symptoms were given to me. Now after receiving these symptoms, I went further. I did his urine report. Because of the patient's privacy and legal point of view, the name has been kept hidden. I'll just show you that his urine indicated a protein urea of 3+ because it was 7 to 8 years old DM. Okay. After treatment of 1 week, you will see that his proteins reduced to 1+. His edema came down. Then secondly, some symptomatic relief in numerical figures also he had. So this was the case. Now, how we solved it, this I will explain you. This is a repertorization table. I'll tell you. When patient came to me, he told us that, sir, I'm here to bring down my creatinine levels. So the rubric selected was from mind section, light desires for. So he wanted some light in his case. Now he had also brought down the biopsy report, which was a pathological diagnosis. So directly I got a rubric, kidneys, inflammation, nephritis, chronic. So this directly rubric we can get in that. Okay. Then he said, when I sleep, all thoughts come to my mind and I get disturbed. So falling asleep late, thoughts rush to the mind. This rubric I found out also in complete report. Now, my observation was he was obese, neatly dressed. So I took a normal rubric presenting at the patient. The generality is obesity. After that, I took a rubric fear marriage. Now you will think, what is the marriage word in this case? Nobody has used this. It is a word also. I will tell you in my way of thinking. See, the patient told us, sir, probably these medicines I have to take forever. So I have to take it forever. I have to live with them. So marriage is a thing where we will live forever till our death and we remain with our partners. But our repertory language, it is taken as, fear of marriage, because he had that fear कि अभी दवाई मुझे पूरी जिंदगी भर मरने तक लेनी पड़ेगी. So that's why this rubric I have to take. Now, vomiting after eating was a very simple rubric which I got. Urine was albuminous. This was also I got. And also, Ajit's repertory, I got a good symptom where there is increased creatinine. You get only few medicines of 1 mark each. They're not so crude. But still, I took that in diabetes mellitus conditions, complications, creatinine increase. On repertorization, I got a table where lycopodium, phosphorus, and arsenic were the 3 leading. So on this mechanical repertorization, we should not depend. We should go back to the code of materia medica and we should compare them. This patient told us, sir, nowadays I cannot tolerate fan and AC even though there are summer days. So he was towards chili. Lycopodium was ruled out. Phosphorus and arsenic were there. But in arsenic, I thought that light disease was not covering arsenic. Here, the patient wanted some relief from creatinine, so he had come to homeopathy. So this basically I took this rubric on that matter. The obesity here I took the rubric which I told you, the fear of marriage. This rubric it does not cover anything. So this rubric I have considered, but I have not considered this in repertorization. Even though he presented in a casual way. Okay. Now why this remedy was selected? I selected this remedy. Patient was chilly. He told us that I cannot tolerate fan now. All the symptoms after giving phosphorus. So I'll go back. I consider the drug as phosphorus as my prescription. Okay. So phosphorus 30 was given to him for 5 days. And the miasm is very important for stages of the disease. He had a nephritis chronic. So syphilitic miasm was considered. We should have miasm mind in mind. Otherwise our medicines will work superficially. And the urine was repeated after 1 week. Here we saw that the proteins from 3 plus were reduced to 1 plus. And also the treatment is ongoing yet. Initially, his creatinine was 3.2 milligrams per dilution, which dropped up to 2.2. He is not in normal range, but the treatment is going on. And I'm continuing with the case. So I would like to just show you this case that how to convert the patient's language into repertory language. So I'll go to the conclusion in 2 minutes now. Friends, DKD is a major health concern and requires an integrated management. Never assess the case only on serum creatinine level. Every time all allopaths tell us creatinine 4 हो गया, 5 हो गया, danger है. Patient comes to us, sir, my creatinine is increasing. Never go on that. See how the patient is present to you. And in advanced cases, we should keep in mind that a homeopath should give us supportive care. Don't make tall claims. Medical legal cases are also increasing. And keep in mind, if the patient comes early to us, it is curable in initial stages. That we should keep in mind. And also, further researches are also needed for a holistic approach. Advanced cases require a holistic approach. So we all branches should come together and work for it. And lastly, I would like to tell you, if you are managing a case of a kidney disease, a homeopath should be confident with the pathophysiology, anatomy, and structural changes and the physical changes going in the body so that he can competently talk with the conventional or allopathic nephrologist on our treatment side. So friends, thank you for your patient hearing. If any questions are there, I request Dr. Dhanesh sir to definitely forward.
Yeah. It's really a very good session indeed. And you really show the beauty of homeopathy in diabetic nephrology, nephropathy, I must say. and how one can, you really guide us to take, what are the route to take, which is the right route to select the remedy, and how to use the repertory in different, what are the rubrics there in the repertory in connected with this nephropathy. Anyway, congratulations, and it's the time for discussion. And those who want to part, since only few minutes remaining, only those who want to have a question, you can raise your hand so that we will allow you to unmute yourself and you can speak to Dr. Indraneel Bawatekar. Doctor, in advanced pathological cases, what you directly simply give the single remedy, or whether you will allow the patient to take some tinctures along with the, what is your methodology of treatment in that case of?
Yeah. Many times I'm giving a call in the ICU, but it is a late call because they call me when the entire organ is failed. In advanced pathological cases, we are very much, we can cater these patients very well. For example, a pain in patients, all conventional medicines are contraindicated for these patients. You can go to give homeopathic medicines good for pain. Uremic symptoms like convulsions, like vomiting, definitely our medicines help a lot, but the totality has to be considered. We cannot consider the chronic phase and treat him. So presenting should be noted down, match with the repertory totality, and then prescribe the medicine.
What's your experience with the Cantharis in all these cases?
Cantharis is good. It works better, but it works temporarily. It doesn't work forever. So in acute cases, this is more helpful.
Yes. What is your experience with lycopodium in those cases?
Yeah, so it's a good question. This is one of the good remedies. And many a times when the patient is hot and is having the you can liver and as well as the renal pathology both matching, lycopodium is one of the wonderful drugs. It covers even hypertension of the patient and it stabilizes in initial stages. Probably it may revert also, but I have not documented any reversal with lycopodium. But it helps in advanced cases also. This is one of the good remedies and a good polycrest, which is well proved. So we should definitely keep in mind.
Okay. When there are renal calculus in both kidneys and the patient is in a diabetic condition, how will you manage the case?
Very true. In such cases, we should not be biased with renal calculus in both the kidneys. We should take the totality which is presenting to us. For example, some patients may not have pain but silent calculi. We should consider the constitution. They have uric acid diastasis. That also we should consider. Acute thermals we should consider. And on that, if you give the medicines immediately in acute stages within 4 to 5 days, the stones, if they are small, they get dissolved and they pass away. But if there is a stagnant calculus, it is a surgical condition. I request everyone in diabetic patients not to deal with stagnant calculus. Better to have a reference and get rid of it.
Okay, so it's a very fine session indeed. And now I invite Dr. M.G. Geeta, a former professor from Government Homeopathic Medical College, to say a vote of thanks to the session. Madam, Dr. M.G. Geeta, please unmute, madam. You are co-host. No response. So I am inviting Dr. Manoj to say a vote of thanks to the session.
Thank Dr. Tanesh. Nice presentation. Definitely, there is no doubt about potential of Dr. Indraneel here. We are really hearing from many times from since now. So this is a very complicated situation and there is no other hope for the patients. So definitely, homeopathy can provide the solace of these persons. On behalf of IFPH, I am expressing sincere thanks to Dr. Indraneel and all those who participated in this session. Thank you.
Thank you, Dr. Manoj, Dr. Indraneel Bawadekar, and those who attend the session. Tomorrow we will have a session from Dr. Nikuj Trivedi from UK, and we'll be talking about multiple sclerosis and homeopathy. With that, we come to the end of the day 1668. Thank you all. Good night.